so I'll just turn it over to her.
Cool, thanks. All right, thanks for having me today, guys. I appreciate it. I hiked it down here from Tulsa after dropping my kiddo off at daycare this morning. So, who wants to go into peds? Oh, I see some hands. Good. Okay, so talk to Susan, and if you have housing in Tulsa, we'll arrange something for you. I just finished having Meredith and Nandini come rotate with me, and they were fantastic, so I'm sure you guys will be equally as prepared and as great of students. So let's see what I can do to help you today to get you into the peds world. It's a little different than adult medicine, as you will find out on your rotations. We are silly and goofy and, find animals in kids' ears and find funny things in their throats and listen to tigers growl in their tummies to make exams fun, rather than an adult where it's quick and easy. Never quite the same with a kid. You have to do a little convincing. But let's start the morning. Let's talk about our littlest of patients. I'm glad to hear you guys had your newborn talk yesterday. Newborns, they're a whole different ball game. Their physiology is a little different, their labs are different, and they're just this tiny little thing that can't tell you what's wrong, and most of the time the parents are clueless too. So it's up to us to be able to really identify abnormalities. All right, let's see, what am I clicking here? Okay, so let's talk about newborn screenings first. Newborn screenings are those little blood tests that we do. Does anyone have kids? Any moms? Okay, cool. So when baby was in the hospital, they do a couple of blood tests. This is part of what we do as a screening to look for any type of physiologic abnormalities. Let's talk about why it's important, why we need to know what it can do and can't do, and then we'll kind of talk about what we do as a screening here in Oklahoma. But real quickly, I want you to read these terms and kind of memorize them, because this is what we're going to talk about. Phenylketonuria, congenital hypothyroidism, galactosemia, sickle cell, congenital adrenal hyperplasia, medium-chain acyl-CoA dehydrogenase deficiency, or MCAD, and cystic fibrosis. Have you guys done your endocrine unit? And have you done your respiratory unit? How about your hematology? Okay, so I'll go quickly over the other stuff because you should know all the sickle cell and CF stuff. Okay, and then we're going to talk about these conditions themselves, and then we'll talk about some testing and treatments and monitoring for these kids. So, why do we do this screening? I want you to memorize this because this is going to be your spiel when some crazy mom's like, I don't believe in doing lab work in my brand new baby or giving them vaccines and I'm only breastfeeding. When they give you that spiel, you say, no, we do the screening to make sure your baby does not have a disease that is undetectable at birth that could be potentially fatal if undetected now. You got that? Memorize that. Okay. And you got to be sassy like that because newborn moms are kind of crazy. I was there, moms, you were there, you don't know what's going on. You got to tell them what's up. Okay, so why do we need to know it? You need to know this test in and out because scared parents are going to need to know the basics and you need to know it well enough to be able to explain it to a parent. It's good to have a parent feel involved in this because this is the first step of getting them involved in their kids' health care. You need to know how to interpret the abnormal results, to know what to do with this kid, and then you need to know, as a PCP, what you're going to do for these kids. All right, so I want you to remember this key word being screening. Newborn screening tests are not diagnostic. They are a screening tool. So with that being said, if you have any positives, they need further workup for confirmatory diagnosis. Also being said, you need to remember that just because a baby screened completely negative, 2-3 months down the line, you could potentially have some abnormalities that you don't think, oh, well, their screening was negative, so they can't have it. That's not true either. Screenings aren't perfect. They are very good. They're pretty specific, so they're good at ruling things in, but that does give you quite a few false positives. But it's very rare that we see a negative that ends up later on being positive. So every state has a different screening. All states are going to test for PKU and hypothyroidism, but in Oklahoma we do a much more broad panel, and 40 of our states test for hemoglobinopathy. I don't know why they all don't. Okay, so there's a little picture for you. To take this screening, the nurses in the nursery are going to do a little heel stick, and they dab it on that card. That card gets sent up here to Oklahoma City to the health department. And generally, when results are negative, they will print out and then get it to the pediatrician. It takes about a month for the negatives. However, if they detect an abnormality, you get a call usually in 2 to 4 days from the health department. I've gotten a call at 8 o'clock at night from the health department. We got a positive on the baby. The nurses are a freak. And then always, you have to do an immediate workup, especially if it's something that could potentially be life-threatening. But most of the time I just tell parents, remember that screening they did? Your baby had Band-Aids on their heel. So no news is good news. If it's a month, it's going to be normal. If anything is picked up, you're going to be hearing from me real soon. And I always reassure them. In my 6 years of practicing, I've only had 3 positives. And of those 3, only 1 of them was true. So, yeah. So that brings us to limitations. We've talked about it's just a screening tool. Positive test always needs to be confirmed. And if that test is positive, they may not truly have the disorder. So it's important in talking to parents when you call them at 10 o'clock at night saying, has the health department called you? Yes, okay, well let's talk about what's going on. It's important to let them know there are such things as false positives on these screenings and further workup is indicated. And you can tell them, every test has a different false positive rate, but for instance, like the, let me give you some examples, like the thyroidism test. It's about a 1 in 800 that turns up positive on the screening that's truly a positive. So, I mean, there's limitations to these. So there you go, high sensitivity, lower specificity. We talked about that already. If you guys remember in stat, take, spin and snout and all of those stat terms. Spin rules it in, snout rules it out. Yeah? No? Okay, that was a long time ago. PA school probably has dumped all that knowledge. Okay, so if the test is negative, the disorder still could be present. So if you see clinical signs of an infant, 2 to 4 months of life, go ahead and do the workup anyway, just because their newborn screen was negative. So that's the most important thing. That's why we see babies so frequently, and you guys probably talked about well checks, you do that right after the hospital. I see my babies back, especially if they're breastfed, I see them back weekly until they're a month old to make sure they're gaining weight and their jaundice goes away. And then after that, 2 months, 4 months, 6 months, then every 3, 9, 12, 15, 18. There's reasons we see kids so frequently at this age, and it's our job to look for any abnormalities that may be presenting in their growth, in their features, or in their development. Usually the hospital's pretty good about asking the parents, who's your pediatrician? And then they send you the results. Sometimes you have to track them down. In the past, it really has not been a problem at my clinic. All right, so in Oklahoma, we test for PKU, hypothyroidism, blah, blah, blah. We've already said all these words. So I want to show you, this is a snippet that I copied from an actual result page from one of my kiddos. So I want you to look, all the disorders are along the left there, and the result, that big important column, they all say in range. That's what you want to see. Look at the reference ranges though. That reference range is telling you what they're actually testing for. So hypothyroidism, they're actually testing TSH levels. All right, galactosemia, they're looking at total galactin level. Let me get to that talk. We'll talk about that. So you can see, hemoglobin, they're looking for fetal hemoglobin. They're looking for phenylalanine levels. So keep those in mind. Those are generally not like a board type question, but in the back of your mind, I want you to know what they're looking for. All right, so let's start talking about these conditions. Let's talk about PKU. Okay, so most of these are autosomal or recessive disorders. So think back to your undergrad genetics class. You had a parent with a recessive, they're, the heterozygous, big A, little a, and then you got the other parent, they happen to also be heterozygous. There's a 25% chance that kid can get both recessive alleles and present. Yeah, that ringing bells? Yeah, I know, dreaded undergrad genetics. So what happens is you get an excess buildup of phenylalanine because it can't be broken down by these kids' bodies. Over time, that phenylalanine is going to build up in their bodies because they can't get rid of it, and too much of that is going to lead to some severe problems. So does anybody have a pack of mints or gum on them? Anything like that? Anybody? So, okay, well if you don't have one, feel free to look if you got one. On the back, under the ingredients, you'll see in big bold letters, it'll say, contains phenylalanine. Do you guys have that? Okay. So phenylalanine is in a lot of things. So next time, you're fixing your dinner, look at the back and see. So things like mints and gum that you don't think of as being, oh, this could be a problem, they put that on the packaging because people with PKU should never eat any products with phenylalanine. We'll get to that. I want you to look at this incidence. 1 in 10,000 live Caucasian births. That's so rare. So rare. Look at this number. Can you see my mouse? No. Okay. That last bullet. Confirmed cases in Oklahoma, 36 in a whole, 14 years? So I've never seen it. My doc has been practicing 30 years. He's never seen it, but it's out there. That's why we screened for it. All right. Next slide. Let's talk about what this condition is. Okay, so you take in some proteins. Your body's supposed to break them down. Phenylalanine is one product. Tyrosine is one product. Phenylalanine should get further broken down by phenylalanine hydroxylase into more tyrosine. So this condition is you are missing that enzyme to break down the phenylalanine into further tyrosine. So keep that in mind because we're going to talk about lab results, and if you keep that process in mind, it's going to make sense why the lab results are the way they are. So what do we see when that phenylalanine builds up? We see these funky, pale kids. The parents may be super tan and have dark hair. These kids have really pale blonde hair, like corn silk hair, not just blonde. I mean, I see a lot of blondes in here. You guys don't have the same, non-pigment color. They have really pale irises, pale skin. We see eczema frequently around the mouth in these kids and other places. But you can kind of see on the top photo, you can kind of see in his cracks of his lips there, he's got some things in that. These kids eventually start having seizures. They have weird limb movements, spasticity, a mousy odor to their urine. Now, I have never smelled it, but that is a board question. Mousy odor on their urine. You think PKU, because it's that extra phenylalanine they're trying to pee out and they can't. And then eventually it leads to irreversible severe mental retardation. If we go untreated, these are like elementary or toddler aged kids. The thing with PKU is it's not fatal. I don't know. I can talk about that for a whole day too. But it leads to severe irreversible mental retardation. The earlier you can detect it, the more you can prevent kids from eating anything with phenylalanine, the less of a chance that they're going to have any type of retardation, or it's not going to be as severe. Even if you catch it at birth, I have to tell you, most of these kids end up with some type of a retardation later in life. It's bad disease. Those toddlers are crazy hyper. Most toddlers are hyper. These kids are bringing it to a whole other level. You see that limb spasticity, so they don't have nice fluid movements. They have really hypertonic muscles. A lot of them start to develop seizures. And then we talked about that eczema-like skin pigmentation, urine has a mousy odor, and autistic-like behavior. So some, keep that on your differential. We'll talk about autism in a little bit. If you see kiddos who aren't developing their communication, social skills, not meeting milestones, and they have super pale skin, hair, irises, and they just are not quite right, keep PKU in your differential. All right, so PKU testing, that metabolic screen that we do, it's important for the nurses to draw it at 24 hours of age or older. There's a couple other tests they do at 24 hours, so if the kid's born in a hospital, usually it's not going to be a big deal. Occasionally I have run into this with my parents that are on baby number 4 and the mom has an all-natural birth and 12 hours later she's like, okay, I'm good to go. Can we go home now? I got other kids to take care of. But really you want to keep these kids in the hospital for a full 24 hours. They get some other screening tests done, and a baby that's 12 hours old, they could be having TET spells at home. All kinds of stuff can happen. Really, 24 to 48 hours is what's recommended. C-section babies usually stay 72 hours, or if they have any blood abnormalities, they stay a little longer. But anyway, so the PKU test needs to be done at 24 hours after birth, or up to 7 days, preferably right at 1 or 2 days old. If you get it before then, they haven't even been in the world long enough to build up enough of these amino acids. So if you rescreen them at 24 hours, or you need to rescreen them by 2 weeks of age if the test was drawn before 24 hours of age. So we're going to look up in their workup, if we do get a positive, we're going to check serum phenylalanine, which should be. No? Anybody? Yes, ding, ding, winner, winner. All right, and then what would serum tyrosine be? Perfect, okay. And then those urine pterins, that's the word for the chemical compound that makes that mousy odor. All right, so treatment, what do? We gotta restrict the phenylalanine. Can't eat any of it. Which is super hard because phenylalanine, I mean, it comes from a protein. You gotta have proteins to live. So these kids usually end up on special medical diets. There's a picture there. Mead Johnson makes a nice phenyl-free formula. And there's different stages of those foods. There's obviously an infant one, a toddler one, and this one is child to adult, the picture right there. But yeah, that's pretty much how they get all of their protein source because we can't let them eat the other stuff. These kids are going to go see endocrine, and they probably aren't even going to go see your local peds endo. They're probably going to go to like the one peds endo in the state that is familiar with treating PKU. That's how rare this is. So here in Oklahoma, they'd end up at Children's over in, well, we're in Oklahoma City. I'm used to talking about Tulsa. But they'd end up with the endo group at Children's, and they would do monitoring. They draw levels on these kids frequently the first couple of years of life. So it's a little bit rough on the kiddos. It's more rough on the parents. I think it's harder to see your kid get blood sticks every week or every other week. Kids get used to it. They're resilient. All right, let's see. Let's keep going here. So yeah, we talked about that mental retardation is not reversible, but it can improve their behavior control if you catch it late. Like say, so I speak Spanish, so I see a lot of Spanish speakers in my practice, and quite a few of them have recently been moving from Venezuela, Colombia, Guatemala, because things are so bad down there. So some of these kids have never seen a pediatrician in their life when they get to us. So say you were to see some kid that's presenting with mental retardation, autism-like features, and you start, seeing some abnormalities on exam, you do a bunch of lab work, and there you go, it might be PKU. So you can talk to the parents that let's change their diet and explain why this is going on. And it may improve their behavior over time, but that mental retardation is not reversible. All right, so here's your diet. I was recently told by one of my students that they have recently seen a question. So remember this. So any high phenylalanine foods, anything with a lot of protein. So anytime you think, I need some protein, what do you go for? Meat, cheese, dairy, eggs, peanut butter. So also to note, aspartame has phenylalanine in it, so diet soda is a big no-no. Low phenylalanine foods, fruits and veggies. There you go. Also to note, wheat has it in there, so these kids also need to be on a gluten-free, wheat-free diet. They can do certain types of breads, cookies, and crackers. A lot of the ones that are made with rice flour and are gluten-free, they can do, but it's always good to check with they'll have a whole team of people helping them, so a dietitian that's familiar with PKU will be helping these kids. All right, treatment and follow-up. That, like we just said, huge team managing these kids. Metabolic or clinical geneticists, nutritionists, genetic counselors, immediate dietary therapy, and you start doing supplemental tyrosine to help support these kids' muscles. They gotta have some protein. And really close monitoring. Like I said, they draw labs on these kids a lot. Weekly phenylalanine and tyrosine levels for the whole first month, and then every other week or every third week for the first couple of years of life. So it kind of sucks having this, but it's doable. It's manageable as a parent. All right. Any questions about PKU? Oh, cool. All right. Let's move on and talk about congenital hypothyroidism. So this condition is a lot more common. We actually do see this pretty frequently. My doc has a patient with this. Most of the time, it's caused by an agenesis or an ectopic thyroid. So can I hear some definitions? Let's clarify those words. What does agenesis mean?
Not forming something?
There you go, not formed. Agenesis. Perfect. What does ectopic mean?
Forming in the wrong place?
In the wrong place, okay. Or a hormonogenesis disorder makes up 10 to 15% of this condition, so they're not forming the hormones correctly like they should be. Can be an autosomal recessive trait. And then smallest incidence is they have a pituitary or a hypothalamus defect that they're not sending that TSH correctly, and that's where it's stemming from. Incidence 1 in 3,000 to 4,000. It is the most common metabolic disorder. Test question. All right, so let's talk about pathophysiology behind it. All right, my beautiful endo students, you remember that hypothalamus, pituitary, thyroid axis. I love physiology, so I can talk about that all day. But okay, so that's functional by 20 weeks in utero. It's fully matured by birth. So by the time this little guy comes into the world, he's able to make his own thyroid hormone and doesn't depend on mom's thyroid hormones anymore. They may appear completely normal at birth, which is scary to think about. They're getting mom's thyroid hormones, so if they are under functioning, that's all right, they're being supplemented, and it takes a couple of months to start to see symptoms. Yeah, the first 3 to 4 months of life, you can see totally normal weight gain, normal functioning, and then it slowly starts to dip off. So yeah, signs or symptoms, it shouldn't be based on that in the first few months of life. If you get an abnormal screen on these kids, you gotta do a workup right away, even if the parents are like, but they're normal, they're so perfect, they're so healthy. And then you say, this is why we do screenings. We don't wanna wait 4 months until your baby starts having problems to address this issue. And then you can read in the notes on this next slide all of the congenital hypothyroidism symptoms. It usually also, just like PKU, leads to mental retardation, poor growth. These babies are scrawny. They just don't grow well. The other key factor to remember is large tongue and a hoarse cry. Anybody know the fancy name for a large tongue? Yeah, macroglossia, perfect. They get kind of an odd puffy look to their face. Most newborns have that look, so sometimes it's hard to tell. They can have a goiter. I'm getting kind of freaky, huh? Now, most newborns do not have much of a visible neck, so that's super important. I think they probably talked yesterday about when you're doing your newborn exam, put your hand under their shoulder blades and lift up so that their little head tilts back. Look under all the creases in their little neck, make sure you don't see any weird lumps or bumps or a goiter. And keep doing that up until they're, 6 months of age when they tend to have more of a neck. Most babies, you just can't see it, they just don't have one. Low metabolic rate. Okay, so just like in your big people that have hypothyroidism, what do you see? They complain of feeling fatigued, they're constipated, they feel like their heart's really slow, they just drag all the time. These babies do that too. So if you're examining a 2-month-old and their heart rate sounds more like an adult rather than an infant, which should be, and well, there you go, get some thyroid workup. Poor peripheral circulation as well. A lot of your adults will complain of cold hands, cold feet. These babies will have that cutest marmorata appearance all the time, even when they're nice and bundled up. All right, there's our little cutie with his macroglossia. You can see no neck. It's got little skin folds there. So if you tilted his neck up, you could probably try and palpate for a little goiter there. He's not super newborn. He looks like he's probably a couple months old. All right. So how are we going to test these kids? So just like in adults, we're going to get a T4 and a TSH. So just like in adults, if they're hypothyroid, what's your T4 going to be? Low, right? Because the thyroid's not cranking out the T4 like it's supposed to be. And what's your TSH going to be? Yes, perfect. Okay. So 10% of the cases can be detected at a second screening at 2 to 6 weeks of age. If there's a family history or if I see any failure to thrive, I'll do the workup. I don't routinely do a second TSH and T4 on a newborn. All right, let's look at this lovely flow chart here, because since this is the most common metabolic disorder, there's a good chance if you go into peds some point in your life, your medical career, you're going to get a positive screen on a hypothyroidism. All right, so you get a call, it's 8 o'clock at night, this baby has an abnormal TSH level. So you're going to have baby come in to see you the very next morning, you're going to do an exam, and then you're going to send the parents to the lab with an order, and you're going to order TSH and T4. So let's say, okay, let me give you a minute, look over that real quick, get oriented on the flow sheet. All right, good, you oriented, you know where you're going? All right. All right, so you get lab work back, and this baby's TSH is 30. Now what are you going to look at?
Venous blood TFT.
Perfect. Okay, so yeah, you want to look at their T4 level now. Let's say their T4 is like tanking, it's like 0.2. What are you going to do with this kid?
Ultrasound.
Perfect. What's that ultrasound going to look for? Yep, I saw somebody do it. Yeah, you're actually looking for a thyroid gland, all right? Ultrasounds are great. There's no radiation to them. They're low cost. It doesn't take a super advanced ultrasound technologist to look for a thyroid. So they're great, and most parents are reassured when moms have had an ultrasound on their belly and they know, oh, it doesn't hurt, it's not bad. They're reassured that their baby is going to be just fine getting it. So ultrasounds are great imaging in peds. Okay, so let's say, okay, they see a thyroid, we're good. We've got a thyroid there. In a couple of weeks, you reorder your TSH and your T4, and now your TSH is 50. And your T4 is still like 0.4. Now what are you going to do? Yeah, you're going to get these kids to endo right away. Get them started on some levothyroxine, just like we do in big people. All right, so now let's say you've got a baby and their TSH comes back as like 14. And now their T4, it's looking pretty good. It's like a 3. Now what are you going to do? Are you going to get an ultrasound on that kid? No, I wouldn't. I'd wait. I'd repeat it in a few weeks. If their TSH levels are kind of intermediate, but their T4 levels are all right, and their exam is normal, I'd give them 3 weeks and redraw. You can usually avoid the cost of an ultrasound. If baby's doing fine and those T4 levels are normal, TSH is still kind of wonky, that's all right. Just repeat it in a few weeks. All right, does everybody feel comfortable with that? Does that make sense? Okay. And this flow sheet is all over the internet. If you ever need a refresher, you can find it very easily. So we talked about levothyroxine. You want to start that as soon as possible, and you want to see these kids every month to check their weight gain and growth and their milestones. Peds endo is going to follow these kids. I mean, as their PCP, you still want to see them to be sure, endo's doing their job and they're not slipping through the cracks. But generally, endo is going to be seeing them monthly as well, as long as they're an infant. If you get that levothyroxine started as soon as possible, it can help prevent mental retardation and the bone growth retardation that we see in these babies. Every study is a little different. In the notes there you can see New England College of Health, they did a collaborative study that showed if you do start it right away, you can have normal IQ. But then some other studies have shown, no, you can't ever reach normal IQ. So the results are out. It's definitely beneficial, but you can't tell a parent, oh yes, your child will be normal if they take their levothyroxine. Don't ever tell them that. One of these days, I hope that will be the case, but right now it's not. All right, any questions about hypothyroidism? No? All right. Okay, let's talk about galactosemia. This one's super rare. 11 cases in that whole time span in Oklahoma. So we'll just do this one briefly. Looky there, autosomal recessive. So they cannot metabolize galactose, which is broken down from glucose. You take those sugars in and you want to make glucose for your body. Galactose should further get broken down into more glucose. There's an enzyme. I can hardly pronounce that, but I'll attempt it. Galactose 1-phosphate uridyl transferase. I'm going to call it GALT. We're getting easy on ourselves. If you lack that GALT enzyme, you can't break it down further, so your body does not get all the glucose it needs. You get a buildup of galactose 1-phosphate, which is that precursor before glucose. It builds up in the liver and the renal tubules and causes big problems. Super, super rare. There's your little flow chart. Lactose breaks down to glucose and then galactose. Galactose should get broken further into galactose 1-phosphate, and then the GALT enzyme is supposed to help that cycle. If they're missing GALT, you can't break it down further into more glucose. Here you go. Here's a lovely little picture for you. Lactose comes from, anybody lactose intolerant? No? Sorry, you don't have to admit it. I'll admit it. I'm lactose intolerant. My kid is too. Lactose comes from milk. Cow's milk, human milk, goat milk, it's all got lactose. So there you go. It's just a nice little picture to help you remember that pathway. No GALT, you get galactosemia, you get buildup, it goes to the kidneys, goes to the liver, also can go to the brain and to the eyes. So severe deficiency, some people can make a little bit of GALT, some people can make no GALT. Depending on the activity of that enzyme, the symptoms can be variable in how they present, depending. So it's always kind of good to remember in general what the presentation is, because it may vary in severity. Usually within a few hours when you initiate feedings at birth, that kid's gonna start puking, they're gonna get jaundice really fast, they're gonna be really lethargic, sleepy. I mean, most newborns have some periods of wakefulness, they don't sleep all the time. These kids do not wanna wake up. And then you're gonna start to notice stuff how to splenomegaly in these infants, which feels really freaky weird. If it keeps going, you're gonna end up with Fanconi syndrome, which will lead to cataracts, cirrhosis, and they usually die from E. coli sepsis. Womp womp. Bad, bad, bad. All right, there's a little lovely picture for you to remember. Enlarged liver, splenomegaly, renal tubules get damaged. You're going to see the kid with jaundice, which jaundice is a whole nother topic. We can talk for an hour about jaundice. Cataracts. In the next picture, I'll show you a little baby with some cataracts. There you go. Infant cataracts. Never good to see. All right, so when we test, okay, keep that pathway in mind. When we test these kids, what are you going to see? You're going to see high galactose, right? It's not getting broken down. You're going to see high galactose 1 phosphate. Again, it's not getting broken down by GALT. But that needs to be measured after milk ingestion. That test is not great. Galactose is a little bit better. And then looking for if you could do a urine test, you can a lot of times see galactoseuria, the body's trying to pee it out, proteinuria, amino acid urea, because it's hurting the kidneys, right? So your kidneys are going to start spilling all kinds of things that shouldn't be spilling. And then you're also going to look at liver enzymes, right? These kids have liver abnormalities because of the buildup, so you're going to see high bilirubin. Now, this is the key thing. I want you to make a note of this. It's not just going to be one type of bilirubin, it's going to be both. And that's the big difference between how you know if it's normal physiologic jaundice in a newborn, their total bilirubin is high. Okay, let me slow down. In galactosemia, both types, conjugated and unconjugated, will be elevated, right? Because the liver is not working, it's not conjugating like it should. In normal newborn jaundice, you're going to get a total and an indirect, or an unconjugated billy. Only the total will be high. Does that make sense? But not both types in a regular newborn jaundice. You guys will talk about jaundice, I'm sure. That's just kind of your basic. Elevated liver function testing, that ALT and AST are going to be high. And coagulopathy issues, right? Your liver is critical in making all of your blood components to help you clot. So these kids could start to present with bruising. If these babies are CERC'd, they could have a lot of oozing, any damage like that. You want to start thinking, okay, what's going on with this kid's liver? All right, what's our treatment? No lactose. There you go, there's your cow. No dairy, no whey. Soy formula that is completely lactose-free is a good option. There are also some other medical formulas that we'll talk about later that are completely lactose-free. It is not good enough to do some of those like Gentle-Ease formulas or lactose sensitivity. Those actually do still have a little bit of lactose in them, and these kids need a medical lactose-free diet. Because of the transporters, they also tend to be a little low in calcium, so these babies usually need some calcium supplementation. Most babies on a soy formula need some calcium supplementation because they don't absorb it very well. All right, so later in life, what are you going to counsel these patients to avoid? No lactose, no cow milk, no goat milk, no breast milk, no cheese, no whey, no curds, no casein, and even no brain. Some cultures, they eat a lot of brain. It's a delicacy. So if you, especially you're considering a patient from a different culture, you need to ask them about their diet. Brain does contain lactose, so no brain for them. Rats. Okay, that's it for galactosemia. Any questions? That was super, super rare. That's like board type stuff. Memorize it, tuck it in the back of your mind just in case you would ever see it, but it's super rare. Now, sickle cell is definitely more common. I've got a little guy with sickle cell, and I've got tons of kids with sickle cell trait. So you've had hematology. I'm not even, you know what this is. I'm not even going to waste my time on it. You know it's autosomal recessive. It's that single abnormal gene. All right, 3 major types. Hemoglobin SS, you'll get sickle cell disease with that. Hemoglobin SC, combined heterozygosity for hemoglobin S and hemoglobin C. These guys don't have this disease quite as severe. And then you can also get a sickle thalassemia, so that beta chain can stick on there sometimes. You know all this incidence. It's most common in African Americans, but I tell you what, don't rule it out. Just because your kid may not be African American, if they're American Indian, which we're in Oklahoma, I think all of us have some Indian blood if you're from Oklahoma. You can't rule that out. So be thinking of that. If you are seeing kids with signs and they may not be African American, do the test anyway. You'd be surprised. All right, signs and symptoms. You guys should remember all of this from your team. Usually by 6 months old, they've at least had one crisis. Most common first presentation, dactylitis. Everybody seen pictures of that? You remember that from your teen lectures? It's awful. I've got a picture coming up. Dactylitis is extreme swelling and bruising of hands and feet, and it's super, super painful. 50% of children before age 3 will present like this. Or if they're more unlucky, they may end up with a CPA or acute chest syndrome, which is a lot more serious than dactylitis. Aseptic necrosis, these kids' spleens don't work so good, you remember that. Yeah, you gotta take the penicillin. And then because of the poor blood flow, you can end up with vagal stress rheumatism and retinopathy. And then, yeah, these kids, they just do not grow well. My little guy, he's like 8, and he's like the size of a 5-year-old. They just do not grow well with this condition. Make sure I got all my notes there. Yep, good. All right, there's your lovely little picture. Here's a nicer picture. You get that sickling, they get clogged. Okay, this is what I want you to remember. You see the hands, you see the swelling, you see the ecchymosis. That is dactylitis. That kid needs to go to the ER in a big city right away. He's going to need a team working on him because he is in sickle cell crisis. And then I threw the other pictures in because I want you to remember too, in older kids, that joint pain is terrible. Terrible, terrible. All right, what do we do to treat these kiddos? They gotta be on penicillin. Those poor little spleens just don't work. My little guy, he's sick. In addition to having sickle cell, he has severe asthma, so he is still on penicillin. They need that Pneumovax vaccine. In addition to their infant ones, they need a dose at 2 and 5 because the most common cause of death in kids with sickle cell, lung infections. Hydroxyurea helps decrease the rate of attacks in these kids. And this is one of those cool drugs that they found out that it works just kind of by chance. We don't know exactly why it works. We do know that it increases the bone marrow production of fetal hemoglobin, and that it helps decrease the incidence of attacks, but we don't know exactly why that is. And obviously, these kids are going to be followed up by a heme. All right, so the bad part about sickle cell when you're kids, and these kids, you know, they want to lead normal lives. They want to go to school, they want to play sports, they want to do all of that. And especially this time of year, they're going to catch every virus that comes their way. Anytime these kids get a fever, they go to the ER right away. Because you just never know. I mean, that, like we said, most common cause of death in these kids, respiratory infections. They got a fever, if they got a developing pneumonia, they need to go be on parenteral IV antibiotics, like stat. And then you need blood cultures. In adults, it's most commonly chronic organ injury and failure, as well as death in adults. All right, sickle cell covered. Check. You guys remember? Is that bringing back memories from your hematology unit? Feel good? Okay, cool. All right, let's talk about CAH. Ooh, looky there, autosomal recessive. It's a 21-hydroxylase deficiency. So we get abnormalities in how the adrenal pathway is supposed to be making its hormones. You don't get the right type of cortisol made. Then, if you remember that feedback, in the next slide I've got a picture there. It's a whole feedback loop. If you don't have enough cortisol being made, then your ACTH levels are going to skyrocket because it's trying to get those renal glands to crank out more cortisol. And then you get, because your poor little adrenal glands are working so hard, they get big, hyperplastic, right? And then because of that, we're going to get an increased production of androgens. And this starts in utero. Okay? Everybody grasp that? This is starting really early in life. 1 in 15,000 live births. I've never seen it. I asked my doc if he'd ever seen it, and he said nope. There you go. There's your refresher, your little picture there. You guys, did you learn the... I taught this to my class last year, and Nandini said, that really stuck with me. The mnemonic for remembering your layers of the adrenal glands? Yes. No? Salt, sugar, sex,
Yeah.
deeper you go, sweeter it gets? Okay. That I still remember that from school, so I'm sure it will help you guys on boards when you take that question. All right, clinical features. Because of those increased androgens, you have masculinization of female genitalia. So back in the 50s, these were the poor little babies that they did like TV shows about, born with both female and male genitalia. You know, they thought these poor kids were freaks, and really all it was CAH. Early virilization in boys because you've got extra androgens floating around, and early accelerated growth. In more severe cases, because of the way the cortisol and ACTH works, you can get a salt-losing crisis. So these kids are going to be sick babies, sick, sick, sick. You're going to know them when you see them. They're going to be floppy, they're going to be hypovolemic, super dehydrated, you're going to get a BMP on them, their sodium's going to be tanking, and their potassium will be sky high. So obviously those kids are going to go to the hospital for workup, and then they'll figure out, oh, cool, let's check their cortisol level. Treatment, synthetic glucocorticoids and mineralocorticoids. Give kids some prednisone, bring that ACTH level down, things get a lot better. For females, a little worse than males because they are born with that usually requires surgical reconstruction. Back in the 50s, up until really the 90s, those kids were taken as newborns or very, very young for reconstruction. And we've had some parents now, they are waiting. There are case studies from these kiddos that as they grew up, they had gender confusion and they felt more male than female, so they kind of wished their parents would have not done the surgery. So that's a trend. If you go into Peds Endo, you talk to your endo about it. But as a parent, that's their right. As long as they can pee okay and they're not having recurrent infections, there's not really any medical absolute need to do the surgery to reconstruct genitalia. But anyway, just something interesting to read about. If you're on Facebook, want to pull up some stories, I'm sure there's some interesting stuff on there. All right, okay, so take notice, that looks like a penis. It's not, it's a clitoris. It's just been giganticized because of the excess androgens. And the middle picture I want you to take notice, look at it, it looks like scrotal tissue. It's rugged, it's folded. It's not, it's labia. So make sure you know what you're looking at when you do that newborn exam. All right, any questions about CAH? Super rare. Super, super rare. It's just kind of one of those cool cases in medicine that you want to know about. If you ever go down on your rotation and they say, oh yeah, my second cousin was born with both genitalia, well now you know what they're talking about. Alright, let's talk about SCAD and MCAD. This is a fatty acid oxidation disorder, so think back to your physiology. When you haven't eaten in a while, your body needs some glucose, it's going to reach out to your liver for some gluconeogenesis, it's going to reach out to your fatty tissues, try and break down, get some energy. These kids can't do that. They don't have the right enzyme pathway, they can't use energy stores correctly, so their glucose levels tank. So in newborns, this used to be, we think, one of the causes of SIDS. These babies, the parents come in and they say, oh, my baby's the best sleeper, they're sleeping 4 to 5 hours at night, and then someday they just don't wake up because these infants need a source of glucose every couple of hours, and if they're sleeping through the night, yeah, kudos to you, Mom, that you're getting some sleep, but if we were to not detect this disorder, that kid's glucose could drop into the 20s and they could, die in their sleep. Mom would never know. So with the development of metabolic screening, we can catch this disorder really early. We can have parents set an alarm to wake up every 2 hours to feed baby as they get a little bigger, past 6 months, then they can wake up every 3 to 4 hours. But it's really key when it comes into play when the kid is sick. Think about you moms, your toddlers at some point have been sick. They don't eat. Kids just don't eat, and they many times don't even want to drink when they're sick. So if you're not getting any glucose into a kid when they're sick, that's a big problem. These kids, I think I'm getting ahead of myself. There we go. If these kids are sick, they may just have a tummy bug. They got to be hospitalized with IV fluids with dextrose. You got to give them some glucose, otherwise their glucose levels are going to tank. There's no cure for it. Mainly medical management is how we do it. Believe it or not, I have a patient with SCAD, and she was a super happy 2-year-old. She's done awesome. We detected it when she was 5 days old. We got her to Peds Endo in Oklahoma City and with their dietitians when she was like 9 days old. And she's done great ever since. And the mom is super involved in her healthcare. Mom's learned a lot. Mom wants to now be an RN. So you never know how things work. All right. Moving on to CF. Look at here, autosomal recessive. Woohoo, seems to be a recurring trend. So this is not just a lung problem, this is an exocrine gland problem. So think pancreas, think stomach, all kinds of issues. So in a little guy, this is going to present as failure to thrive because they've got malabsorption syndromes, they can have lots of diarrhea, really lethargic, coughing all the time. Mom might mention they just have a really runny nose all the time. And you guys probably remember, we don't have great treatments. Gosh, compared to 10 or 20 years ago, our treatments have come a long way, but there's no cure for CF. It's a sad, sad disease. So we're going to help them out by giving them fat-soluble vitamins. We're going to do lots of breathing treatments to help bust up that mucus so their lungs can work better. Got to treat those lung infections aggressively, and then think about pancreatic enzyme replacement too. These kids are going to go see a host of specialists to help them out. All right, there's your beautiful little CFTR channels. They don't move chloride right. You get that thick, nasty mucus. And there's a little pictogram reminding you of all the areas that may cause problems in the child's body. So what are we going to do order-wise if you get a positive screening? You're going to send them to the hospital. We're going to do sweat chloride testing. So, sorry, I've got St. Francis in there. Children's does them here. I think Baptist might do them too. But anyway, it's non-invasive. They just hook up these little electrodes to this little guy's arm. There you go. Got a picture. Nothing scary. It might be scary for mom, but baby's chill. No big deal. And then you get results fairly quickly. Okay, couple other things. We're wrapping up with the blood screening stuff that we do, but I want to also quickly talk about the other tests we're going to do for a newborn at 24 hours of life. So we're going to test their hearing. I wanted to make sure to throw a picture on there of what a newborn hearing screen looks like, so if a parent is ever scared that their baby's going to go into the back room of the nursery and have a test done, you can tell them, oh no, we just put a little sticky on their head, we play some sounds for them in their ears, and we watch their brain waves to make sure their brain responds correctly to the sounds. Hearing is so critical in kiddos because it affects their speech development starting at birth. So the earlier we can identify any hearing abnormalities, the quicker we can get these kiddos hearing aids, the better their speech and communication will be later on. It's very common for these screening tools, again, this is a screening, it's not a diagnostic test, really common when they do this at 24 hours that baby will have a unilateral fail. So maybe just the left side, it'll say refer on the printout, and the right side will pass. In that case, the nurse is going to repeat it at 48 hours. 98% of the babies will pass both sides by 48 hours on exam. The babies that don't, you have to follow up in your clinic, and when they're a month old, you send them to an audiologist or the health department to repeat that hearing test. Normally at that 1 month, if they failed on one side, it's going to be normal. But that's how we catch any type of congenital deafness, and we get those kiddos to a pediatric audiologist for hearing aids right away, or cochlear implants. So with remediation, by 6 months of age, we can see normal language and social development like in other babies. It's incredible. And I'm sure you guys have seen on Facebook all the cute videos of the baby's hearing aids being turned on for the first time. It's amazing to watch. When you send a baby off and they get the hearing test, you're talking with the mom all the time, mom's freaking, oh my gosh, my baby can't hear. You get them to the audiologist, they come back in a few months with their cochlear implants, and that baby is like a whole new person. It's so cool to see. I think I've got 3 with cochlear implants and like probably 4 or 5 elementary age kids with hearing aids. So it's more common than you think. All right, so we talked a little about early hospital discharge. We really don't want that baby going home before 24 hours of age. That's, as a pediatrician, when you have a baby in the hospital, you do an exam on them every 24 hours to make sure that nothing's changing, no new murmurs, they're peeing fine, pooping fine, no development of jaundice. If they do get discharged from the hospital, I make them come in to me the next day. It's just not worth it. Yeah, I get it. You want to go home, but the baby's health is just as important as mom's. When they do go home, we don't want them following up any later than a week. And if that newborn screen got collected before 24 hours, remember we talked about earlier, you want to repeat it before the baby's 2 weeks old to make sure you're not missing anything. The other thing we check at 24 hours is a bilirubin level. So, have you guys had a jaundice lecture yet? Yeah? Okay, cool. So you know that bilirubin levels are dependent upon the age of the baby in hours. In this beautiful little chart, you can see across the horizontal axis, we've got time, how old baby is, and then on your vertical axis, that's the total bili. It's really common for breastfed babies to have a little bit of jaundice. That bilirubin just does not bind to breast milk as well as it does formula. And that's okay as long as it's within normal levels and baby is still feeding okay and peeing and pooping. You just follow baby super close. Sometimes you have to make them go every day to get a blood draw, even outpatient, until baby's down within normal limits. Probably in my whole time of practice, I probably had 5 babies tops on Billy Lights in the home. Sometimes the nurseries will stick babies under Billy Lights to help them out a little bit to get that bilirubin conjugated and help pee it out, poop it out. But most of the time, by the time they go home, the levels are down, they're starting to get better intake, they're peeing better, they're pooping better. But anyway, so let me tell you a story and then I'll give you a little case practice. Let's see what time we get. 5 to 11? Okay. Okay, so this is kind of weird and twisty, I guess, but wait till you practice, you'll be the same way. I had a kid last week that baby was born and was term, no history, prenatal history was perfect healthy baby. At 12 hours of age, I think I went and saw the baby at like 16 hours old. That baby was yellow, like highlighter yellow, which is really abnormal. It usually takes a few days. If it's breastfeeding jaundice, it happens later on. So by like 16 hours old, this baby was yellow. And mom was like, he's just really tired, he's not eating well. And I'm just like, oh crap, this is not good. That kid's 16-hour bilirubin was 12. I was like, oh shit, this is really bad. So I called my doc and I was like, doc. And to make matters worse, the kid's was Coombs positive. You guys talked about Coombs test yet? Yeah, so Coombs is like the DAT, the direct anti-glutamate, anyway, antibodies. This is bad. This is like mom's immune system attacking baby's blood cells. That's what Coombs positive usually means. So I called my doc and I'm like, Dad, I need your help. He's like, what's wrong? He's asleep. I'm like, I got a baby in the nursery. It was Sunday. I was like, I got a baby in the nursery. They're Coombs positive, and their 16-hour Billy is like a 12 or 13. And he went, oh shit. It's just not very common. You don't see it a lot. And he was like, well, are they eating? And I'm like, oh, not great. No, their input is not great. They had past 1 meconium, so I was like, all right, good, things are moving. And the mom was like, oh, my first son had bilirubin. I think his bilirubin at 24 hours old was like a 15. And so now I'm thinking, oh, now it's something hereditary, crap. So anyway, we did a ton of lab work on that kid. Thankfully, he was at the hospital connected to my office, so I was walking over there once or twice a day, just checking on the baby. The nurses were all panicked, and the mom was like, oh, no big deal. Oh, breastfeeding is just great. Anyway, so needless to say, I had to help that baby out a little bit. Before he got super lethargic and wouldn't latch at all, we set up a supplemental nursing system. You guys seen one of those? The moms may have heard of one. Okay, so formula helps get rid of the billy faster, right? So we always want to have super high billy babies and start to do some formula along with the breastfeeding. I never tell moms to stop breastfeeding. We want them to breastfeed long term, that's the best for the baby. An SNS is like this little bag that you can either hang on an IV pole or drape over mom's shoulder. There's a little tiny tube that you tape to the side of mom's breast so that the opening of the tube is right by the areola. And so then baby will latch to nurse and they'll get formula as well as breast milk. So SNS are awesome, especially mentally for a new mom who's exhausted and stressed, and if you're having people tell you, oh my gosh, your baby's jaundice is really serious, you need to take this seriously. The worst thing as a parent is to feel helpless. So an SNS allowing mom to keep nursing is about the best thing you can do mentally for a mom that needs to supplement with some formula. Plus it prevents nipple confusion. You've heard they don't want babies taking passies in the nursery until they're a couple weeks old because they want them to be good nursers. Okay, so there you go. This way they don't have to take a bottle. So there's all those kind of little things in peds that it just takes time and practice that you see. And then especially having your own child that you start to realize, oh my God, how did I practice peds before I was a mom? I knew nothing. So SNS, we got that baby on an SNS. We were doing every 8 hours Billy levels. And by day 2, that baby's level went up to 15.2. So it was a scary, scary deal. We got that baby on continuous lights. Levels came down to a 12 after 12 hours of light, so I was like, oh, good, okay. So we were trying to avoid putting the baby in the NICU, because what happens when the babies get so sick, they stop to eat, they're lethargic, and if that jaundice level gets too high, it's going to cause brain problems. So you send them to the NICU, you put an IV in them, which in a little tiny baby usually goes in their head, which is terrifying for any parent. And you put them under continuous lights, and that interrupts breastfeeding, so that part really stinks. Anyway, so there's my case for you. I haven't had a case that severe in my entire practice, and it just happened last week, so you just never know. All right, so let's do a little case scenario. Okay, let's say you go see your baby in the nursery. They are just at 24 hours old, and that baby's level is a 7. What are you going to do? Takers? Anybody? What do you think? Look at that chart. Find your 24-hour mark. Scroll up to about, what's roughly a 7.
Repeat 40 times.
Yeah, I'd repeat it in 12 hours. Thankfully, baby, probably not going to get discharged. If that mom is like, I don't want to go home, it's 24 hours old, I'm going to say, baby's jaundice, you need to stay. Okay, so then 12 hours later at the 36-hour mark, mom's been nursing, baby's peeing and pooping, things are going good. Levels have come down to like a 5.8. What are you going to do now? Yeah. Have them come back to your clinic, follow up in a couple of days. That's a good scenario, and most of the time, that's what you will see. Most jaundice cases, yeah, their levels may be a little bit scary for a couple of days, but with good nursing, good intake, good pee and poo, and parents can do UV therapy at home, especially if it's a sunny day, strip baby down to the diaper, sit with them in a window. A lot of parents don't understand. You need to explain to them the lights touch the baby's yellow skin, and it makes the bilirubin mix better, and so they can pee and poop it out. I had one mom that was like, well, we're sitting in the window, but I was worried he was going to get cold, so I put a blanket over him. Anyway, you have to explain exactly what you want parents to do, very precisely. Okay, so let's talk about, you're seeing a baby in clinic that was born in a different hospital. Baby is 3 days old and looks kind of jaundiced. So you send them over to the lab, you get their total billing back, and say at this point it's like 14. What are you going to do with that kid? Yeah, so I would probably have the baby go back in 24 hours to the lab. At that point, baby's a few days old. What type of jaundice is more common? Few days in life versus right away? Breastfeeding, very good. So, with breastfeeding jaundice, you want them to keep nursing. You do this home sunlight therapy, have them pee and poop it out. In 24 hours, they go back, and then let's say it's already come down to like a 12. You good, right? Yeah, no worries. Does that make sense? Is that helping you guys figure out practically what you do with this little chart? Okay. If you go into PEDS, there's a great app that has an awesome billing calculator on it, and it has antibiotic dosing. It's called PD Quick Calc. It's a little blue icon that has 2 little white foot imprints. So I think it's like $2. If you guys really want to wow your PEDS preceptors and have this on hand, I would strongly recommend it. It's the best PEDS app I have found out there. PD Quick Calc. Yeah, good. Got to jot it down for later? Okay. But yeah, it's got a really fantastic little billy doser you put in. Okay, so like 48 hours from birth, and it's a 12. And then it plots a little dot for you right on the little chart, and it shows you where you are, and then it gives you guidelines. So it's handy. And that's just one of the tools. It's got all kinds of great stuff in there. All right. I think we are about done. Oh yeah, and then why I've been preaching this whole time. You guys need to know this stuff well enough that you can reassure a scared parent. That's all there is to it. I'm sure parents in the room, you guys can attest that when you have a doctor or a PA that can sit down and explain what's going on calmly, and you are confident in your provider, it makes having babies so much easier. All right. We already talked about that. Okay, and then there's some resources for you if you're interested in this stuff. You want to learn some more.